welcome all, both physical and virtual, to the second day of the ML. And it's my pleasure to come back to a familiar point, speaking about a topic that has been very much scrutinized in a very trivial way. And the pleasant surprise for me as a speaker, when I come and talk again and again about uterine bleeding, is that this is an evolving topic. As much as it is trivial and as much as it is benign, the question of uterine abnormal and dysfunctional bleeding has more and more become critical. And that's for the simple reason that the quality of life for the female population has become more as well taken into consideration from other perspectives. So that also concerns endometriosis, that concerns PCOS, and so forth. Every time I speak about this topic, I present the definition which is presented, which is put, or the title put by the National Institute of Health about abnormal uterine bleeding. And reading that summarizes how confusing is the entity. When they say that this abnormal uterine bleeding occur when a woman experiences a change in menstrual loss or the degree of loss or vaginal bleeding pattern that differs from the experienced by the age-matched general female population. As confusing as it is, this does summarize the problem that we gynecologists have every day in defining the patients that come to us and trying to identify whether they do have an abnormality in their bleeding or not. So we always go from what are the basics: the normal menstrual cycle, the follicular phase where you have the dominance of the estrogen followed by the ovulation, and then you have the luteal phase, which both of them supersede with proliferative and secretory phase. So these are the basics, and the deviation from that has started by defining what is the duration, what is the length of the period, what is the volume of the loss. This has been modified by the FIGO to kind of expand the time of the frequency up to 38 days or less to 24 days, with a duration which is considered to be prolonged only if it is more than 8 days. And this also has been revised to kind of minimize that gap, because we already know that 8 days and 7 days, they are considered to be a prolonged period, and that 38 days and above, it is considered to be a less frequent period. But coming back to the main causes of dysfunctional bleeding, mainly, it is endocrine-related pathology. And I will be coming to this point when we consider the genesis, but such pathologies like insulin resistance, polycystic ovarian syndrome, thyroid function, hyperprolactinemia come into the front line. Of course, less or rare causes as drug use and anomalies, congenital anomalies can be a cause. But the anovulatory dysfunctional uterine bleeding comes from a deviation from an axis which I will not pretend that I myself understand completely, and which is the hypothalamus pituitary ovarian axis. This is the axis which goes in correlation with the endocrine system and which regulates the ovulation. So if the woman doesn't have enough progesterone, there is no ovulation. The effect of unopposed estrogen, as we know, will lead to continuous proliferation of the endometrium with resulting abnormality of the bleeding, as well as irregular shedding and eventually possibly hyperplasia. So these are dominant pathologies mainly in the pubertal and in the perimenopausal periods. This is a nice slide which I like to highlight because it doesn't only speak about uterine abnormal bleeding. It also correlates with the entity of adenomyosis. And I'm going to refer to this as well, because in my opinion, adenomyosis is going to merge more and more as one of the main pathologies that dominate the abnormal uterine bleeding in the mid and late reproductive age. But what you see here, this is the functional layer that is responsible for the regular or irregular shedding of the endometrium. However, and as was showed nicely in the first session today in the imaging session, and especially by Dr. Vannuccini's slides, this is the subendometrial layer with the spiral vessels that usually cascades into the infinite cycle of bleeding when the woman goes into this vicious cycle of continuous and heavy bleeding. So that is where the angiogenetic properties happen with an abnormal subendometrial and myometrial layer. So we know the FIGO classification of the pound coin, and I'm not going into the detail about the structural and functional, but however, what I want to again highlight in this is the bridging, which I consider to be critical between adenomyosis and coagulopathy. So these are separate entities. However, they should be considered with regards to these two features, adenomyosis and coagulopathy, as bridging over. And that's where we need to rethink as well the classification out of simply structural or simply functional. Now, adenomyosis, as was defined very nicely in yesterday's lectures, is a benign disease that is characteristic with the same features of endometriosis, which is an ectopic endometrial tissue that penetrates into the myometrium and acts as an independent and stromal glandular cells in the basalis layer that I showed you. And as was also highlighted by yesterday's lectures, that certain trauma to the uterus, like dilatation and curettage, multiple deliveries, spontaneous abortions, will only exacerbate adenomyosis in mid and late reproductive age woman. So the altered uterine contractility is the main culprit in the secondary dysmenorrhea genesis, with the continuous menorrhagia that is usually resistant to treatment. This is mainly the cascade where invasion of the endometrium follows by repeated tissue injury and repair, and the sex steroid receptors and the proliferation and fibrosis are the main two factors in the pathogenesis of adenomyosis, followed by inflammation and neuroangiogenesis. Now, this is a picture that you saw from the previous slide about the role of fibroids and the 0 to 2 location in causing bleeding. But nowadays we know that even the other subclassifications would cause disruption of the contractility of the myometrium and reflect on the fecundity and the sustainability of the pregnancy in women who has these type of fibroids. This is a classic. I always like to go back to Spiroff in defining the approach to dysfunctional uterine bleeding. Spiroff is 90s in the academic years, and what he mentioned is that a variety of bleeding manifestation of anovulatory cycles can be confidently managed without surgical intervention by therapeutic regimens founded on sound physiologic principles. And if we know what are the physiologic principles, then we will be able to utilize the arsenal of therapeutic measures that we have in the proper and effective way to stop the bleeding. This is a definition of what is what is the classification of menstrual abnormalities. Most importantly, of course, is the metrorrhagia, and followed by menometrorrhagia, which is either the heavy bleeding or the heavy intermittent bleeding, and as well dysmenorrhea, whether it is primary or secondary, and amenorrhea. Now, symptoms and consequences is the reason why we try to convince a patient, and namely in her mid-reproductive age, that she needs treatment. We know now that our female population is more and more into the working pipeline, and that they are engaged in social and working activities. And we more and more deal with patients who come to the hospital just to load with iron injections, with blood transfusion, and then go back to work without being able to handle or to deal with their disabling uterine bleeding. And this is a shame. This is a shame for us, because we're not able to deal with these patients and convince them that there is a way, and probably because we are not able to manage this pathology of uterine bleeding in a manner that is besides dealing with the symptomatic or the aftermath. So basically, when it comes to luteal insufficiency and anovulation, and as I said, the non-opposed estrogenic effect, we meet with the consequences of anemia, miscarriages, and eventually endometrial hyperplasia and possible cancer. Or is it that? And for the surprise of it, and for a new publication that was presented recently from Harvard, these studies that were done classically, a survey, this is a survey in London of around 800 participants in college age, just to try to show the impact of menstrual bleeding on the daily activities. So how these participants are not able to continue their college studies and so on. This is from Dublin, so they are similar studies. But such surveys do not touch the nerve, because, again, as I mentioned, the female population is much more engaged in their working and productive activities to be busy with such trivial issues. Or are they trivial? So this study, which is a prospective epidemiological study that was done in Harvard in the US, on the projection of 30 years, around 80,000 premenopausal women were enrolled into this study, and they were requested to report their usual length and regularity of the menstrual cycle at the ages from 14 to 46. And the Department of Nutrition Epidemiology and Brigham in Boston followed these women, and they wanted to study the normal functioning of the axis that I mentioned, the hypothalamic pituitary ovarian axis, and to compare the results with existing results from before. So basically, they have associated the irregularity of the period with a high or greater risk of non-communicable diseases like ovarian cancer, coronary heart disease, type 2 diabetes, and mental health problems. But the characteristics here were scheduled, as I mentioned, from adolescence to adulthood. And they were classified by questionnaires that were repeatedly sent and received from this population. And eventually, the result of this study showed that irregular and long menstrual periods come to a consequence of early death. So these women who had irregular and long menstrual period had higher risk and defined for death before the age of 70 years. And this is in a way breaking news, because now we are looking at what we consider to be as a trivial and benign, irregular, long menstrual period, which might, besides the other causes of diabetes, hyperinsulinemia, ovarian cancer, and so on, actually cause shortening of the physiological life of a woman. And this is the first type kind of itself study that is prospective on a long-term period, and that has been followed up by the index of surveys, as well as looking into the death registration in an official manner. So what they came to find that the effect of long cycle length and smoking on mortality, suggesting that the menstrual cycle dysfunction might interact synergistically with smoking to further increase the risk of premature mortality. This is not surprising given the well-documented protective effect of abstinence from smoking. But this interaction is also biologically plausible. Women with long and irregular cycles already have an adverse metabolic, cardiovascular, inflammatory risk profile, which can be further exacerbated by smoking. So these are two independent factors. It's not only smoking, but irregular and long cycles by themselves. And the final conclusion that was reached by the American Academy of Pediatrics and American College of Obstetricians and Gynecologists, that the features of a long irregular cycle has to be taken as a vital sign of woman's health. So the same thing like we consider obesity, smoking, diabetes as vital signs in a woman's health, this study suggests that irregular and long periods has also to be considered as one of the vital signs in the prognostic, in the prognosis of a life expectation. And I think this requires some reflection because it changes the way that we address the issue. I'm not talking about frightening our patients again, but I'm talking as physicians and gynecologists that we need to arm ourselves in a better way to study the profile of these women who start having long irregular periods in their adolescent time and later in their premenopausal as risk factors, try to treat them in a better way, and of course, to try to find underlying endocrinological conditions that might correlate with the life expectancy. These are the surgical treatments that we try to avoid usually, so as not to put the woman at risk of unnecessary surgeries unless it is for diagnostic purpose. But as I mentioned as well, because most of these, dilatation, curettage, ablation, will cause further damage to the myometrium and will exacerbate adenomyosis in the likelihood of its existing in not less than 30 to 35% of female population. Medical treatments can be non-hormonal and hormonal. And usually they are given with the purpose to prevent excessive bleeding and to regulate the cycle. These are the main titles. And what gives us a priority in choosing a medical treatment over the other is the degree of the bleeding, because you cannot treat an acute hemorrhage with oral contraceptives, as well as an age-related factor with the risks and benefits that you can have when you advise for a certain hormonal treatment. Of course, the need of contraception, and last, adverse effect profile, which we know that is important to avoid non-compliance. Tranexamic acid is a golden medication. Tranexamic acid is a lifesaver, especially in obstetrics, and it's been put as the list of essential medications by the WHO. And it's a golden medication, if you remember the slide that I showed you, because in the moment of the vicious cycle of angiogenesis and the spiral artery malformations, this medication can act to stop, at least symptomatically for a while, the progress of the recurrent menorrhagia. It has side effects, but the rare ones are pulmonary embolism, DVT, and anaphylaxis. Hormonal treatment mainly is divided between progestogens and estrogen, but progestogens is the main effective formula for treating irregular and heavy menstrual bleedings. And the agents that we deal with are the most common progesterone, dydrogesterone, medroxyprogesterone acetate, norethindrone, and levonorgestrel. The first three, progesterone, dydrogesterone, and medroxyprogesterone acetate, are mainly targeting the lining of the uterus by encouraging the shedding, while the norethindrone and levonorgestrel aim at thinning the lining. And this is important to understand because if you use norethindrone and levonorgestrel in certain categories of women, adding to the damage that is happening to the lining by thinning, you will have atrophic bleeding. So it's extremely important to estimate and to analyze the benchmark of the endometrium in these women prior to giving them more potent drugs like norethindrone or levonorgestrel. Repeat it. Yes, so progesterone, dydrogesterone, and medroxyprogesterone acetate, these are from the category of progesterones, and I will come to the family tree of the progesterones that only encourage the shedding. So they oppose estrogen without having an atrophic effect on the endometrium. Hence, if you give these drugs, this will be an ongoing process that will take time until there is a balance between the exuberant effect of the estrogen versus what you are giving, whether it is dydrogesterone, progesterone, or MPA. While neta and levonorgestrel are potent drugs that actually act on atrophy. So basically, the lining will eventually shed to the point of atrophy, exposing the subendometrial layer and causing oozing or an open surface that will continue bleeding by effect of angiogenesis and not by effect of hormonal disbalance. And that's an important point to recognize when you are choosing your progesterone. Estrogen, on the other hand, is like tranexamic acid. We don't have it, we cannot use it, but in acute phases of bleeding, that's the saving mechanism when you have this thin lining or when you have this irregular shedding, and you need to stop that, so you just simply add estrogen to build the lining before counteracting later on with progestogens. This can be achieved by OCPs. So instead of giving, for example, IV estrogen, and in case you do have an acute bleeding, OCPs can come in handy if you can use them properly by giving, for example, the estrogen tablets until the bleeding stops, and then continuing with the regular cycle given or masked by the OCPs. So progestogen, in its biological or physiological features, stops, like I said, the overproduction of an non-opposed effect of the estrogen. It stabilizes the endometrial structure, as well as it minimizes the effect of hypercontractility in the uterus, and that's why we use it in pregnancy. It initiates the clotting mechanism by as well the hemostatic effect and antifibrinolytic effect through the PI pathway, which is the plasminogen activator inhibitor, and it inhibits the MMPA, which is one of the factors in the coagulation disturbance. So that's why progestogens can act hand in hand with tranexamic acid at certain periods. This is the family tree of the progestogens, and they are divided between the progesterone, the retroprogesterone, and the spironolactone derivative. To the progesterone, this is the 17 and the 19 derivatives. We know from them the classic MPA and hydroxyprogesterone caproate, as well as cyproterone. 19 progesterone derivatives is the older generations in the OCPs. Retroprogesterone is the only derivative that is giving dydrogesterone. and I'll speak about it in a minute, while spironolactone derivatives is the drospirenone, is the new agent in OCPs that is an anti-androgenic and that we use usually for several purposes, including the aesthetic effect of it. So dydrogesterone is unique in the purpose of being synthesized and enhanced by light, and it has a bond between carbon-6 and carbon-7, which makes its binding different from the other progestogens. And this is important also to understand later when I am going to compare between this progesterone and another progesterone. Why do they differ? Why do they have different affinities? It is because of this natural structure and this bond that makes this dydrogesterone or this agent more potent in a certain way and more effective in another way. Now, this is a study just to show you the molecular properties. When you are giving a progestogen, you want also to have an in-phase secretory effect. That means that you want to mimic the cycle. So the OCPs, we know the OCPs will cancel the cycle and they will come into action and they will create their own kind of cycle. While dydrogesterone and netta are the only progesterones that are similar in action to progestogen, the natural progestogen. And this is a study that was done on postmenopausal women. So they were all given estradiol for a certain period of time, followed by these 4 agents: netta, norgestrel, medroxyprogesterone acetate, dydrogesterone, and progesterone, 5 agents. And as you see, dydrogesterone and netta were the closest in creating in the curettage sample an in-phase effect similar to progestogen. Now, this is a series of studies that was done to show the effect of dydrogesterone in the management of irregular cycles. This is Saldana and Naib giving dydrogesterone in the luteal phase and showing the effect on the regularity of the period. This is an interesting study which was done in India on 16 to 19 years of age, 50 girls who did have irregular cycles, mainly menorrhagia. And they were given dydrogesterone in the same cyclicity. And you can see that there was almost 96% response to the regularity and the regularity of the cycle in 6 cycles time. And the endometrial thickness, which was measured prior and after the 6 cycles, was decreased to 8 and 12 millimeter respectively. So this is a very effective medication, even in the early postmenarchal irregularities. Now, these are studies that were more enhanced. This study by Anklesaria showed simply that after regulating the cycle by giving dydrogesterone in the 11 to the 25, the effect continues for 3 months later on after the cessation of the treatment. And we do find that in practice, that women who take this medication and then stop it, they do have an after effect for at least 2 to 3 months where the continuation of the cycle is regular. This is the same study by Anklesaria to show the quality towards the volume or the flow of the bleeding. And this is the same thing showing the continuity of the effect 3 months after the cessation and the inhibition of menstrual pain. Now, there is also a series of multi-center prospective studies that were done. This one was from Eastern Europe, Podjolkova, and the same multi-center single-arm prospective study was done by Trivedi in India, and they all gave their patients in the studies twice daily dydrogesterone in the luteal phase for up to 6 cycles with a clear response, whether towards the regularity of the bleeding, towards the pain reduction during the menstrual period, and the volume that was less at the end of the cycle treatment. Now we come to another classic, Schindler. Adolf Schindler is the founder of the Progesterone Club, European Progesterone Club, and this is a classification of all the progesterone products. And here where we enter into what I asked you to remember about the structure of dydrogesterone, because that gives dydrogesterone the unique feature of having less affinity to any other receptors except for progesterone receptors and estrogen receptors. And this is clearly mentioned in the classification given by Schindler. The affinity to progesterone receptor is only comparative to medroxyprogesterone acetate. Otherwise, netta and dydrogesterone has the highest affinity to progesterone receptors. This is also by Schindler. And this is, again, a list of the receptors, whether it is mineralocorticoid, glucocorticoid, sex hormone binding globulin receptors. And you can see that it's only dydrogesterone that has an affinity to progesterone and estrogen. This is the classification and pharmacology of progestins publication that I mentioned by Schindler. And it follows as well the same table showing dydrogesterone as unique progesterone in having singular affinity to the receptors without causing any side effects by affecting the other receptors. One more important slide about the physiological friendly effect of dydrogesterone in the body. This is a study that was done by Balash, and it's in mid-reproductive age women where dydrogesterone was given during the cycle with a control of the cycle, where it showed that the plasma levels of the natural progesterone does not differ. And why is this important? Because dydrogesterone in its also natural composition will not alter the natural production of the endogenic hormones in the body. And this is important for your women who are planning to conceive, who are planning to get pregnant, because there is no other progestogenic agent that will be neutral or indifferent to these hormones. So if you give any other progesterone, the cycle will be altered by either anovulation or alteration of the plasma levels, and we will discuss that later. So now I'm going to compare, I will rest the case into comparing between two very popular and very strong progesterone agents, which is the netta and the dydrogesterone. And we both know that netta, norethindrone, has been mentioned in many lectures before. Professor Engin Oral very beautifully had an illustration of the medical treatment between oral contraceptives and progesterones, and netta was in the front line together with dydrogesterone. So they are similar, except that norethindrone is a testosterone analog. And I will emphasize on that just in a second. They have the affinity for progesterone equally. However, as you see here, the androgen receptor affinity for dydrogesterone is 0, while it is 15% for norethindrone. And that explains part of the side effects that netta can have amongst women by having headaches, hair growth, and certain other side effects that are related with the androgen receptors. This is another comparison between the effect of these two medications. And one important notice that inhibition of the ovulation, as I mentioned, happens with 0.5 milligram of norethindrone per day, while dydrogesterone will need to be given 30 milligram per day to reach that effect of anovulation. Estrogenic activity is derived from norethindrone, and androgenic activity, as I mentioned, from netta can affect the skin and hair growth. So coming to the point that they are both safe, and the tolerability is comparative, because netta can have these side effects with some women, might not have it with the other, fluid retention, edema, vaginal bleeding. But the most important thing when we discuss this is that norethindrone is a testosterone analog. And I will jump to another thing, which is the investigation. These are studies that has been done. As you know, you give GnRH. You give GnRH, and now the recommendation is once you start GnRH, you need to give add-back therapy. So you cannot wait for 3 months or 6 months. And some of these add-back therapies is HRT, and many times you want to avoid HRT because of the side effects or let's say enhancement of risk for breast cancer and so on. So these studies were done on progesterone components that can be given as an add-back therapy in synergy with GnRH. And the progesterones that were studied was MPA, NET, and NETA. And as you see, NETA was effective at 5 milligrams for 12 months. Why? Because NETA undergoes hepatic metabolism to ethinyl estradiol. And this gives two-pronged effect. So you have the ethinyl estradiol that provides bone effect and reduces vasomotor instability. And it has a direct effect on the endometrium. That's why you can use NETA as an add-back therapy with GnRH. And that's exactly why you cannot give NETA for a woman who's planning pregnancy or who is pregnant. And this is important. Why? Because again, when we're dealing, of course, with abnormal uterine bleeding, both agents are very good and they can act in different ways in a potent way to stop the bleeding or to regulate the bleeding. The difference, and as you see here, that if you want to maintain the cyclicity of the period, not to stop the period, not to minimize it to the point where the woman becomes confused, and you know how important it is for women to have this clock signal that she has a period which is regular, it will be difficult with the norethindrone to give enough dosage to keep the cycle while maintaining an amenorrheic or a regular period. While with dydrogesterone, you have the flexibility of starting with the minimal dose of 10 milligram and raising it up to 30 milligram while calibrating whether you want your your patient to become pregnant, or if it's not an option, then she can go to the highest dose. So basically, my message is that, first of all, well, we'll come to the message, but the one regarding norethindrone and dydrogesterone, that they are both very potent drugs, but they act in different ways and they are not similar. And it's extremely important that when we are giving our patients to realize how is that going to affect the compliance, the efficiency, and the satisfaction of the patient. So these are three main things that we have to think about. It's not only important to dry out the patient, it's important that she continues with her treatment as long as needed, and that is the long-term management that you have to think about. So for dysmenorrhea, dydrogesterone should be given in a 3 weeks interval, not only through the luteal phase, because that will basically have an effect throughout the cycle and not only in the luteal phase. While in irregular cycles, it could be enough to give it throughout the luteal phase while changing the dose according with the satisfaction and the side effect possibility. And it can be given also as a safe drug in the very start of a heavy bleeding at the highest dose possible. So the take-home message is that abnormal uterine bleeding is a social morbidity. It's not a casual incident. Every woman throughout her life will have irregular bleeding. The question is whether they are consistent and they are altering the physiological pattern of her life. And we know that the irregular bleeding can affect, abnormal uterine bleeding can affect all stages of reproductive age. And the prevalence that is reconsidered is 30%. Wang study that I just presented for you suggesting long and irregular menstrual cycles are associated with an increased risk of death before 70, which means a shorter life expectancy. We cannot emphasize on what to do and how to do, but that is very closely related with the, like I said, the alterations in the hypothalamic pituitary ovarian axis. And this has to be studied with each woman that has this consistent pathology regarding hyperinsulinemia, cardiovascular, polycystic ovarian diabetes, and so on. The estimated economic loss in itself, which nobody speaks about, is approximately anything between 1 and 12 billion dollars. And abnormal uterine bleeding by anovulatory disorders that are caused by anovulation should be managed conservatively. The only reason to do curettage is for diagnostic reason, if you are suspecting, for example, malignancy, or if you have actually profuse bleeding with an identified thickened endometrium that might require therapeutic curettage, and that is even questionable if you can do that with a progesterogenic crash dose. Surgical methods for treatment of IUB should be considered, as I mentioned, only if everything else is exhausted. Dydrogesterone is a selective progesterone receptor, and that's where it is unique with its metabolic effect as a progesterone, and it does not inhibit the natural cycle of the woman. Hence, it can be used prior to conception and after being pregnant, and it does not inhibit ovulation at the recommended dose. It effectively transforms the endometrium, as I illustrated in the studies on the postmenopausal woman, and it's suitable for treatment in almost all the phases of the reproductive age. And recent studies has showed, as I showed you, that it is effective in regularizing, minimizing the bleeding, and dealing with dysmenorrhea. And I hope that this message came now through another kind of emphasis with the new epidemiological study of Wang. And I'm happy to open the panel now for discussion for this lecture and the previous lectures as well. Thank you so much.